Hey everyone, let's talk about viral hepatitis. So, the terminology for acute and chronic viral hepatitis can be confusing because the same word hepatitis is used to describe several different entities. Okay, so firstly, hepatitis is applied to diseases which are caused by viruses, hepatitis A, B, C, D, and E virus. And these viruses are hepatotrophic, which means they have a special love for liver and they like to reside in the liver. Secondly, hepatitis is applied to patterns of acute and chronic hepatic injuries produced by other viruses such as Epstein-Barr virus, cytomegalovirus, and yellow fever, as well as autoimmune reactions, drugs, and toxins. In that case, for example, we'll call it as autoimmune hepatitis, which I've already discussed in a separate video. You can check that out. But in this particular section, we'll be discussing these hepatotrophic viruses, and then we'll discuss the clinico-pathological characteristics of acute and chronic viral hepatitis. So let's start with hepatitis E virus. This hepatitis E virus infection is usually benign and self-limited, and it does not cause chronic hepatitis. And rarely, in about 0.1% of cases, it produces fulminant hepatitis. So this infection is generally very mild. It will be self-limited and it won't be progressing into chronic hepatitis or fulminant hepatitis. Now, HAV has an incubation period of 2 to 6 weeks. This incubation period you'll have to remember for all these viruses. And this HAV, it is typically cleared by the host immune response, so it does not establish a carrier state. So there will be no chronic hepatitis, no fulminant hepatitis, no carrier state. Okay. So the infection occurs throughout the world and is endemic in countries with poor healthcare infrastructures. Acute HIV tends to cause a febrile illness associated with jaundice and non-specific symptoms such as fatigue and loss of appetite. Overall, HIV accounts for 25% of acute hepatitis and it does not cause chronic hepatitis. Now, what kind of virus is this HAV? So it is a non-enveloped positive strand RNA picornavirus that occupies its own genus hepatovirus. Now, how it spreads? It spreads by ingestion of contaminated food and water, and it is shed in the stools for 2 to 3 weeks before and 1 week after the onset of the jaundice. Okay, so that's why close personal contacts with an infected individual or fecal oral contamination accounts for most cases and explains the outbreak in institutional settings such as schools and nurseries, as well as waterborne epidemics in places where people live in overcrowded, unsanitary conditions. Now, HIV can also be detected in serum and saliva of infected individuals. In high economic countries, sporadic infection may be contracted by the consumption of raw and steamed shellfish that have concentrated the virus from seawater contaminated with human sewage. Infected workers in the food industry are another source of outbreak. Now, HIV itself does not seem to be cytopathic, but the cellular immune response, particularly that involving cytotoxic CD8 plus T cells, play a key role in HIV mediated hepatocellular injury. Because HIV viremia is transient, blood-borne transmission is very rare. Therefore, donated blood is not screened for this virus. Okay, but it will be screened for HBV. Now, IgM antibody against HIV appears in the blood at the onset of symptoms and is reliable marker for acute infection. And it is true for other hepatitis viruses also. This IgM antibody will appear at the onset of symptom and it will be a marker for acute infection. Now, fecal shedding of the virus ends as the IgM titer rises. The IgM response usually declines in few months, followed by the appearance of IgG anti-HAV that persists for years, often conferring lifelong immunity. Hepatitis E rates have declined by more than 95% since introduction of the vaccine. Now, this was all about hepatitis A virus. It is very mild, very benign, not progressing into chronic hepatitis or fulminant hepatitis, and not giving rise to a carrier state also. Now, if we talk about hepatitis B virus, which is very important, the outcome of HBV infection, it varies widely. Okay, so it could lead to what? It could lead to acute hepatitis with the recovery and clearance of the virus, very mild, or non-progressive chronic hepatitis, or progressive chronic disease ending in cirrhosis, or fulminant hepatitis with massive liver necrosis, and also as an asymptomatic healthy carrier state. So these all things which HAV was not doing, HBV can do. Okay, now HBV induced chronic liver, this is the summary table which we'll talk about in the end. So this HBV induced disease is also an important precursor for development of hepatocellular carcinoma. So this is also a risk factor for hepatocellular carcinoma, and liver disease due to HBV infection is an enormous global health problem. Okay, now one third of the world's population has been infected with HBV, and 250 million individuals have chronic infections. 75% of chronic carriers live in Asia and the Western Pacific Rim. Now, these are all epidemiological data, which is not so important if you're sitting for the exams and you won't even remember this. But again, we have to remember what all can be the progression in case of hepatitis B virus, and then the mode of transmission. Now, how it is transmitted, it varies with the geographical locale. In high prevalence regions, perinatal transmission during childbirth accounts for 90% of the cases. As we remember, in case of hepatitis A virus, it was mainly through contaminated food and water, but in case of hepatitis B virus, there could be perinatal transmission during childbirth. And in areas of intermediate prevalence, this is an area of high prevalence region. In areas of intermediate prevalence, horizontal transmission, especially in early childhood, dominates. Spread among children usually occurs through minor breaks in the skin or mucous membrane following physical contact with infected individuals. Then, in case of low prevalence areas, unprotected sex and intravenous substance use are the chief modes of spread. So, in case of hepatitis B, you have to remember the mode of transmission in high prevalence regions, in this thing intermediate prevalence, and in low prevalence region. These are different. Then transfusion related spread has been reduced greatly because we screen the donated blood for HBsAg, and by stopping the practice of paying blood donors. Vaccination induces a protective antibody response in 95% of the individual. Now, HBV is a member of Hepataviridae, a family of DNA viruses that cause hepatitis in multiple animal species. The HBV genome is a partially double-stranded 3200 nucleotide and circular DNA with 4 open reading frames which encode the following proteins. So, first one is the nucleocapsid core protein. This is HBCAG. C is for core. Okay, and a longer polypeptide with a pre-core and core region designated HBeAg. This is hepatitis B E antigen. The pre-core region directs the secretion of HBeAg polypeptide into blood, whereas HBCAg remains in the hepatocytes. So this HBCAg remains in the hepatocytes where it participates in the assembly of the virions, whereas this HBeAg, this directs the secretion, this will be into the blood. So we have seen two things, HBCAg and HBeAg. Now next up is envelope glycoprotein, which is the HBsAg hepatitis B surface antigen. This is very important because infected hepatocytes, they synthesize and secrete massive quantities of non-infective envelope glycoprotein, which is this HBsAg. Next up we have a polymerase with both DNA polymerase activity and reverse transcriptase activity, which enables genomic replication to occur through a unique DNA to RNA and then again DNA cycle via an intermediate RNA template. This unusual polymerase is the target of drugs used to treat hepatitis B infection. So, this is a special polymerase. Why? Because it has both polymerase activity and reverse transcriptase activity. As you can see over here, when we were talking about hepatitis A infection, these are the changes which will be seen in the serum. So, in cases of acute hepatitis A, we have the incubation period which is 2 to 6 weeks in case of hepatitis A. Then we have the acute disease phase where will be the signs and symptoms like jaundice and non-specific symptoms like loss of appetite and fever, and then there will be recovery. So we have the incubation period. After that we'll have this IgM anti-HAV, which will be the first antibody to rise around 2 to 12 weeks, and then it will decrease, whereas IgG will raise later, but it will persist. Okay, so this was for hepatitis A virus. If we talk about hepatitis B virus, the incubation period is a bit longer. In case of hepatitis B, it is 2 to 26 weeks, and unlike hepatitis A, it remains in the blood during active episodes of acute and chronic hepatitis. Approximately 65% of adults with newly joined hepatitis B have mild or no symptoms and do not develop jaundice. The remaining 25% have non-specific constitutional symptoms like fever, jaundice, right upper quadrant pain, and fulminant hepatitis and chronic hepatitis are uncommon, occurring in 0.1 to 0.5 and 5 to 10% respectively of patients who are acutely infected. In most cases, the infection is self-limited and resolves without treatment, but chronic disease develops in 5 to 10% of cases who are infected. Now, the risk of chronic infection is inversely related to the age and is greatest, about 95% in infants who are exposed to the virus through transmission from their mothers at birth. Okay, so it is inversely related to age, and infants are at higher risk of transmission, higher risk of developing chronic infection. Now, chronic hepatitis may progress to cirrhosis, and a subset develop hepatocellular carcinoma also. Now, the host immune response is the main determinant of the outcome of the infections. As we already seen, there could be 5 outcomes of hepatitis B, and which outcome will occur, this will depend on the immunity of the host. Innate immune mechanisms, particularly the production of interferon alpha, protects the host during initial phases of infection, and a strong response by virus-specific CD4 and CD8 plus interferon gamma producing cells is associated with resolution. Like HAV, HBV is generally not directly hepatotoxic, and most hepatocyte injury is caused by the CD8 plus cytotoxic T cells attacking the infected cells. Now, the course of the disease can be followed clinically by monitoring the serum markers. So, what happens is this HBsAg, which we just read, they appear before the onset of the symptoms, and they peak during symptomatic stage and then usually decline to undetectable levels in 12 weeks. Okay. By contrast, HBsAg persists in cases that progress to chronicity. So, this could be understood by this graph over here. We have 2 graphs. First one is where an acute disease leads to the recovery, and in second graph wherein an acute disease will lead to a chronic disease. What we have just seen is that we have the incubation period and then we have the markers. First one was we were talking about HBsAg over here. This HBsAg starts increasing before the onset of symptoms, but it is peaking during the symptoms. Along with this, HBsAg, HBV-DNA and HBeAg also will peak during the symptomatic stage, and thereafter it will decrease and will become normal from around 12 weeks to up till 20 weeks. It will be becoming normal. But in cases where this acute disease will progress into a chronic disease, these markers HBsAg, HBV-DNA and HBeAg, it will not become normal, it will not become undetectable, it will persist. Okay, so this was the first point. If we talk about the next thing, we have this anti-HBs antibody. It appears after the acute disease is over and is usually not detected until a few weeks to several months after HBsAg disappears. Okay, so the first thing which rises is this HBsAg. After this disappearing of this HBsAg, which occurs around 12 weeks, thereafter anti-HBs antibody will appear. Okay, anti-HBs antibody may persist for life and confer protection, which is the rationale for HBsAg containing vaccines. Then, by contrast, anti-HBs antibodies are not produced in cases that progress to chronic liver diseases. Okay, so what it's saying is that in case of acute disease, after the disappearance of HBsAg, there will be anti-HBs will be appearing. Okay, it's starting from over here. No, when this HBsAg disappears, anti-HBs will rise and it can persist throughout life. But in cases where this acute disease will progress into chronic disease, there will be no anti-HBsAg. There is no anti-HBsAg. Okay, now the third thing is HBeAg and HBV-DNA. As we have already discussed, they appear in serum soon after HBsAg, and they signify ongoing viral replication. The persistence of HBeAg is an indication of progression to chronic hepatitis. The appearance of anti-HBe antibody implies that the acute infection has peaked and is waning. Now, next up we have IgM anti-HBc. They become detectable in serum shortly before the onset of the symptoms and concurrent with the onset of elevated serum aminotransferase levels, which are an indicator of hepatocyte destruction. Over a period of month, IgM anti-HBc antibody is replaced by IgG. Okay, treatment of chronic hepatitis B and HBV polymerase inhibitor with HBV polymerase inhibitor and IFN alpha can slow the disease progression. It can reduce the liver damage and prevent liver cirrhosis or liver cancer, but it does not eliminate the infection. Okay, so this is a very important graph and it is almost every single time asked in the exam. You should remember which is the first thing to increase. We have HBsAg, which is increasing and it is peaking during the symptomatic stage, then it is going down, and when it disappears, then occurs the anti-HBs antibody, and a persistence of this HBe antigen and HBs antigen. What it means that it is progressing to the chronic disease. And after that we have the IgM anti-HBc, which is in acute, and in cases of chronic there is IgG anti-HBc. Okay, so you have to remember these graphs. This here shows the potential outcomes in cases of hepatitis B infection. If in case of acute infection, it can be subclinical disease, acute hepatitis or chronic hepatitis. Okay, in the subclinical disease, in almost 100% cases leads to recovery. Even acute hepatitis in almost 99% cases leads to recovery, but in less than 1% cases it can lead to fulminant hepatitis and can cause even death of the patient, or there could be a need for transplant. In case of chronic hepatitis, it can lead to recovery, but in 20 to 30% cases it can lead to cirrhosis and or HCC, hepatocellular carcinoma, which can eventually lead to the death of the patient or even a need for transplant. So this was all about hepatitis B virus. Now we are going to talk about hepatitis C virus. Now, hepatitis C is a major cause of chronic liver disease with approximately 170 million individuals affected worldwide. Now, HCV is a blood-borne infection. Notably, there has been a decrease in the annual incidence due to what? Due to primarily to a reduction in transfusion-associated cases as a result of effective screening process. Okay, so if you remember, HAV not screened, but HBV and HCV are screened before transfusion. Okay, it is worrisome that these gains may not be sustained. There is a recent increase in new HCV infection primarily due to ongoing opioid epidemic and occasional injectional drug use. Until recently, the number of patients with chronic infection appeared likely to continue to increase, but new therapies are improving the outlook. Now, the risk factors for HCV infection are what? Intravenous substance use, needle stick injury, and perinatal transmission of HCV at the time of birth in about 5 to 6% of infants born to HCV infected mothers. Okay, so what about this HCV? Hepatitis C virus, it is a member of Flaviviridae family. So just as with HIV, an understanding of viral replication and assembly has facilitated the development of highly effective anti-HCV drugs, which we'll discuss just now. So HCV is an enveloped single-stranded RNA virus with a genome encoding in a single polyprotein that is processed by several proteases into 10 functional proteins. Included among these proteins is a protease that is needed for complete processing of the polyprotein NS5A, which is essential for assembly of HCV into mature virions, and the RNA polymerase that is necessary for replication of the viral genome. Okay, because of the inability of the host immune response to eliminate HCV and the low fidelity of HCV RNA polymerase, new genetic variants develop at a rapid pace. This has led to the appearance of 7 major HCV genotypes worldwide, each with or more subspecies. Infection in most individuals are due to virus of a single genotype, but new genetic variants are generated in the host while viral replication persists. As a result, each patient usually comes to be infected with a population of divergent but closely related HCV variants known as quasi-species, which means it is very rapidly regenerating and developing its subspecies while the virus is replicating inside the host body. Now, incubation period, I already told you, you'll have to remember for all these viruses. For HCV, it is 4 to 26 weeks, which is almost similar to hepatitis B, with a mean of 9 weeks. In about 85% of individuals, the acute infection is asymptomatic and goes unrecognized. HCV virus RNA is detectable in blood for 1 to 3 weeks, coincidental with elevation in serum transaminase. The clinical course of acute HCV hepatitis is milder than that of HBV. And in this case, severe acute hepatitis is very rare. Persistent infection and chronic hepatitis are the hallmarks, okay, of HCV infection despite the asymptomatic nature of acute illness. Means the acute disease will be very mild, non-symptomatic, but there will be persistent infection and chronic hepatitis. In contrast to HBV, chronic disease occurs in majority of the individuals. Okay, and cirrhosis eventually occurs in approximately 20% over a period of 20 to 30 years. The mechanism of chronicity is not well understood, but the factors responsible could be older age, male gender, alcohol use, immunosuppressive drugs, hepatitis B, HIV co infection, and disease associated with insulin resistance like obesity and type 2 diabetes mellitus and metabolic syndromes. Okay, now what happens when it progresses to chronic HCV? There is circulating HCV RNA persisting in 90% of the patient despite the presence of neutralizing antibodies. Hence, testing for HCV RNA is done to confirm the diagnosis of chronic HCV infection. Will test for HCV RNA. A characteristic clinical feature of chronic HCV infection is episodic elevation in serum aminotransferase separated by periods of normal or near normal enzyme levels. Okay, so there will be episodic elevation in serum aminotransferase. Even patients infected with HCV who do not have normal transaminase are at high risk for developing permanent liver damage, and anyone with detectable serum HCV RNA needs treatment and long-term medical follow-up. Fortunately, recent years have seen dramatically improvement in treatment that stems from development of drugs that specifically target the viral protease, RNA polymerase, and NS5A protein, all of which are required for production of the virus. So we can give a combination therapy with these drugs. So this shows the life cycle of hepatitis C virus. Herein we can see the entry of the virus inside the cell. This is a virus containing the RNA and nucleocapsid, and we have the lipid envelope. So it is binded with these receptors, with the help of these receptors, and it is entering the cells through endocytosis. After entering the cell, there is fusion and uncoating of the virus, which leads to the exposing of this RNA outside. Now what happens is we have the cell nucleus and we have these folds. Now after entering of this genetic material inside the host cell, then it is translated in rough endoplasmic reticulum. So we have the rough endoplasmic reticulum in the cells and it is translated. Then after translation there is viral assembly again forming the envelope and all, and then it is released. Now what is happening during this translation is that there is in the endoplasmic reticulum lumen, what is happening, we are requiring protease enzyme and we are requiring RNA polymerase for synthesis of this antisense RNA template. Okay, this is needed. So that's what has been told, that in recent years we can target different steps in this viral replication. We can target the protease, we can use protease inhibitors, and we can target this NS5A proteins, we can use NS5A inhibitors, or we can target this RNA polymerase, and we can use the combination of these medicines to which is very effective. So we can use a triple drug therapy which is very effective. So this was all about hepatitis C virus. And now if we talk about hepatitis D virus, which is also known as the Delta agent, it is a unique RNA virus that is dependent for its life cycle on hepatitis B virus. Okay, now infection with hepatitis D arises in following settings. It could be a co-infection. So this is very important. It could be a co-infection. What it means is that following exposure to serum containing both hepatitis D and hepatitis B. Okay, so co-infection means both are there. Co-infection can result in clinical syndrome that is indistinguishable from acute hepatitis B. It is self-limited and usually followed by clearance of both viruses. However, there is a higher rate of acute hepatic failure in individuals who use intravenous drug. Next thing is superinfection, and what it means is that there is a chronic carrier of hepatitis B and who is exposed to a new inoculum of hepatitis D. So there is no co-infection. First there was a carrier of hepatitis B and now that person is superimposed or super infected by hepatitis D also. This results in disease 30 to 50 days later, presenting either as severe acute hepatitis in previously asymptomatic HBV carrier or an exacerbation of chronic hepatitis B infection. Chronic HDV infection occur more than 80% of superinfection and may have two phases. First one is an acute phase with active HDV replication and suppression of HBV associated with high transaminase levels, and second phase is a chronic phase in which HDV replication decrease, HBV replication increase, and transaminase levels they fluctuate. Now, HDV infection occurs worldwide and affects an estimated of 15 million individuals. Its prevalence is in Africa, Middle East, and South Italy, etc. In most higher income countries, it is largely restricted to individuals who use intravenous drugs and those who had multiple blood transfusions. Okay. Now, this co-infection increases the risk of progression to cirrhosis and hepatocellular carcinoma. HDV RNA is detectable in the blood and liver at the time of onset of acute asymptomatic disease. Anti-HDV IgM is a reliable indicator of recent HDV exposure but is frequently short-lived. Okay. Now, when chronic hepatitis arises from HDV superinfection, HBsAg is present in the serum and HDV antibodies persist for months or longer. Because of its dependency on HBV, HDV infection is prevented by vaccination against HBV. Because if there will not be any hepatitis B virus, there won't be any hepatitis D virus. Okay. Now the last one is hepatitis E virus. So E is for enterically transmitted, which means waterborne infection that usually produces a self-limiting disease similar to what we have read when we were talking about hepatitis E virus. Okay, so the virus typically infects young to middle-aged adults, and it is a zoonotic disease with animal reservoirs that includes monkeys, cats, pigs, and dogs. Now, epidemics have been reported in Asia and Indian subcontinent, sub-Saharan Africa and Mexico, etc. So this is the chart for temporal changes in hepatitis C infection, which we have already read about. We were talking about hepatitis E infection. So hepatitis E is an unenveloped positive stranded RNA virus in Hepiviridae family. Virions are shed in stool during acute illness. Before the onset of clinical illness, HEV RNA and HEV virions can be detected by PCR in stool and serum. The onset of rising serum aminotransferase, clinical illness, and elevated IgM anti-HEV titers are virtually simultaneous. Symptoms resolve in 2 to 4 weeks, during which time the IgM titers fall and anti-HEV IgG titers rise. Now, if we talk about clinicopathological syndromes of viral hepatitis, as already discussed, infection with hepatitis virus produce a wide range of outcomes. Okay, so major features of main clinicopathological syndromes are what? First one could be acute asymptomatic infection with recovery. Patients in this group are identified incidentally because of elevated serum transaminases or presence of antiviral antibodies. HAV, HBV infections, particularly in childhood, are frequently subclinical. Okay, so this could be the first thing that could happen. There will be an acute asymptomatic infection and there will be recovery. Next up, what could happen? We can have acute symptomatic infection with recovery. So means there will be an acute infection, there will be symptoms like jaundice, fever, and all those things, and but there will be a recovery. Okay, now next what could happen is acute liver failure, wherein this viral hepatitis can lead to acute liver failure. HAV is the most common cause worldwide, but HBV is more common in Asia and Mediterranean. Survival for more than 1 week may permit recovery to occur via replication of residual hepatocytes. Okay, other thing that can happen is chronic hepatitis, wherein there will be symptomatic, biochemical, or serological evidence of continuing or relapsing hepatic disease for more than 6 months. In some patients, the only sign of chronic disease are elevation of serum transaminase, and lab tests can reveal impaired liver function, such as prolongation of PT and hyperbilirubinemia. Occasionally, in cases of HBV and HCV, immune complex disease develop that results in vasculitis and glomerulonephritis. Now, other thing that can happen is a carrier state. What is a carrier? A carrier is an individual who harbors and can transmit an organism, but who himself has no symptoms. Okay, so the carriers include individuals who harbor the virus but have no liver disease, or individuals who harbor the virus and have asymptomatic non-progressive liver damage. In both cases, particularly the later one, affected individuals, they constitute reservoirs of the infection. HBV infection acquired early in life in endemic areas give rise to a carrier state in more than 90% of the cases, whereas in non-endemic regions the carrier state is very rare. Okay, so now if we talk about the morphological changes in the liver in case of hepatitis, so what it will be in acute viral hepatitis, the liver will be normal in size, or it could be enlarged due to inflammation, or it could be shrunken due to liver necrosis due to acute liver failure. Microscopically, there is a portal and lobular inflammatory infiltrate comprising predominantly lymphocytes, variably admixed with plasma cells and eosinophils. Hepatocyte injury may result in necrosis and apoptosis, and necrosis of groups of hepatocytes, that is confluent necrosis, can be seen in severe cases and can progress to necrosis of the entire lobule, that is panlobular or panacinar necrosis, or to connect vascular structures such as, which is known as bridging necrosis. Okay, now liver failure can develop with massive hepatic necrosis. If we talk about chronic viral hepatitis, what will happen is the defining histological feature is portal lymphocytic or lymphoplasmacytic inflammation, and there will be fibrosis as in case of any chronic infection. The inflammatory cells often cross the limiting plate and injure periportal hepatocytes. So this will be the interface activity, means the inflammatory cells will break down the limiting membrane and they will injure periportal hepatocytes. This may be accompanied by a variable degree of lobular inflammation, and fibrosis develops with increasing liver damage, manifesting initially as portal and periportal fibrosis. Then the fibrous septa develop and lead to portoportal bridging fibrosis and eventually cirrhosis. Certain histological features point to specific viral etiologies. In case of chronic hepatitis B, ground glass hepatocytes. What are these ground glass hepatocytes? These are cells with endoplasmic reticulum swollen by HBsAg. They are a diagnostic hallmark, and presence of viral antigen in these cells can be confirmed by immunostaining. Liver biopsy involved by chronic hepatitis C commonly show large lymphoid aggregates. Often hepatitis C is associated with fatty change in scattered hepatocytes. Bile duct injury is also prominent in some cases of hepatitis C and mimic the histological changes seen in primary biliary cholangitis. Okay, so as we can see over here, in case of acute hepatitis, we can see mononuclear infiltrate, but it is very scant as compared to the chronic hepatitis where there is dense mononuclear infiltrate. If we talk about the hepatocyte injury, there could be ballooning degeneration, there could be apoptosis, necrosis, cholestasis, and aggregation of the macrophages. But if we talk about chronic hepatitis, there could be bridging fibrosis, means fibrosis between portal tract and central vein. Okay, there could be interface hepatitis, which means the hepatic plate is broken. Okay, and there could be apoptosis, fatty change, and all those things will be the same. But for example, this ground glass cells, these are characteristic hallmark of hepatitis B, wherein we can see where there will be accumulation or hepatocytes containing HBsAg. Okay, so these will be the clinical signs and symptoms of hepatitis, acute and chronic. In this photomicrograph also we can see ground glass hepatocytes in chronic hepatitis B. They are caused by accumulation of hepatitis B, HBsAg, hepatitis B surface antigen. Okay, so we can also see abundant finely granular pink cytoplasmic inclusions with specific antibody confirms the presence of surface antigen. On IHC we can see it. Okay, now this was all about viral hepatitis, and to summarize this, we'll go to that table which summarizes the all the things related to all the viruses. Okay. So here is the table which is describing all the viruses. The genome in case of hepatitis A, B, C, D and E. Okay, the viral genome in case of hepatitis A, we have single stranded RNA, and viral family is hepatovirus related to picorna virus. Route of transmission is fecal-oral, contaminated food and water. Incubation period 2 to 6 weeks. Frequency of chronic liver disease never. Diagnosis is by detection of serum IgM antibodies. So if we talk about hepatitis A, you can remember hepatitis E is very much similar to this. We have same single stranded RNA, but viral family is Hepiviridae family. Same is the route of transmission. We have fecal-oral, almost similar is the incubation period 4 to 5 weeks, and this chronic liver disease will not happen. It will happen only in immunocompromised host only. Diagnosis is through detection of serum IgM and IgG antibodies and PCR also for hepatitis E virus RNA. Now if we talk about hepatitis B, this is partially double-stranded DNA. The family is hepatnavirus. The route of transmission is parenteral, sexual contact and perinatal. Incubation period is longer, 2 to 26 weeks. Mean is the 8 weeks. Frequency is 5 to 10% of converting into chronic liver disease. Detection is through HBsAg or antibody to HBsAg, PCR for HBV DNA. In case of hepatitis C, it is a single-stranded RNA. The family is Flaviviridae. Route of transmission is parenteral. Intranasal cocaine use is a risk factor. This has a almost similar incubation period to hepatitis B, which is 4 to 26 week, and most important, it has a more than 80% frequency of progression to chronic liver disease. The diagnosis could be through ELISA for antibody detection and PCR for HCV RNA. In case of hepatitis D, this is delta. It is circular defective single-stranded RNA, subviral particle in delta viridae family. Route of transmission is again parenteral. It is the incubation period will be same as HBV, and frequency of chronic liver disease will be 10% in cases of co-infection, but 90 to 100% in case of superinfection. Okay, what co-infection and superinfection means we have already discussed this. Diagnosis is through detection of IgM and IgG antibodies and HDV RNA in serum and HD antigen in liver biopsy. So this is the summary table for all the viruses we have seen, and this was all about viral hepatitis. Thank you so much for watching.